I think we are ready to get started for our webinar today. I'm Ferris Taylor, and I want to welcome all of you and thank you for joining this webinar. This is the latest installment of our HCG hosted webinar series. We do one about every month. And today's presentation is led by one of our HCG sponsor partners, CareCentrix. And we thank them for their efforts in working with us to put this material together today. I do see a number of our HCG member colleagues on the call, but in addition, there are many of you that are new, and we thank you for taking your time to be with us. Just a few housekeeping items for today's webinar. All participants are on mute. We will have time at the end of the presentation for questions. So if you have a question, type it into the question box that you see in the lower right-hand corner of the screen. And we can encourage you to try it out now to test it in the question box. Just say hi and tell us what caused you to want to listen in on the webinar today. We'd appreciate that. If you're on your phone, you may also tweet questions to @HCExecGroup. So HCExecGroup. And we will take the questions that way as well. We'll follow up afterwards if we don't get to all of the questions with email responses. And in addition, after the webinar, there will be an email address for Juliana Ruiz, our administrator, jr@hceg.org, where you can send questions or additional comments. The webinar is being recorded and will be shared again. I'll be brief about HCG because I know we all want to get into the content of the webinar. We're a national network of healthcare executives and thought leaders, actually celebrating our 30th year in working together to reshape healthcare. We interact regularly throughout the year across multiple channels, such as these webinars, periodic face-to-face executive roundtables, white papers, blogs, and we have a bi-weekly newsletter. By facilitating those frequent interactions and then culminating in our annual forum, HCG Annual Forum, we provide a platform for networking and industry-leading discussions. You can always learn more about HCG at hceg.org. Throughout the year and culminating in that annual forum, our members discuss and debate a broad range of critical issues and priorities in the industry. We then formally vote at the annual forum and create a top 10 list. That becomes our program, our education calendar for the coming year. Today, we're going to focus on the number one and highest ranked issue, clinical data and data analytics, especially sharing clinical evidence to better manage health and to drive decisions. But as you know, the topic of data analytics is woven into the very fabric and the infrastructure of most everything we do in healthcare, including this discussion today. Today's webinar is entitled Financial Impact of Post-Acute Care in Medicare Advantage. And our thought leaders today are Dr. Karen Johnston and Marcus Lasner from CareCentrix. Dr. Johnson is the medical director at CareCentrix, and after training as an internist at University of California, San Francisco, she was a partner in a 50-physician group practice. She's been a medical executive in several cardiovascular prevention programs and co-founded eMed Bracelet, a personal electronic health record. She also serves on the board of Bridges to Communities, working in Nicaragua and the Dominican Republic. Marcus is the VP of Market Development and Strategy, where he leads product strategy and growth at CareCentrix. And as you can see, he has considerable experience in consulting in pharma, biotech, and healthcare services. Marcus, I think you're going to kick off our discussion today, so I'll pass the slides to you.
At CareCentrix, we really focus, and our mission is really focused on finding the best ways to lower costs in healthcare. And for us, one of the largest, best ways we've identified is to better manage post-acute care. And what we see is we're talking about about some of our core principles here. We find that post-acute care today, which we'll go into a lot more detail, is really siloed, resulting in waste, and success requires a lot of clinical coordination, alignment, and engaging patients and caregivers and the entire care team. What we find is when those issues are left siloed and not addressed, they lead to worse outcomes and higher costs. And through our experience, we've identified ways to drive $10 to $20 in PMPM savings for our health plan partners, which can have critical and very impactful improvements in any kind of post-acute management and bed. We're going to walk through a few things today. First of all, talk a little about the opportunity. I'll hand it over to Karen to talk about pathways and identifying the right pathways for each patient. Talk a little bit about what this means for a member experience and how to really optimize that experience, and then some specific action steps that we can take to drive that value. The opportunity, as we view it in post-acute care, is driving care to the home. At CareCentrix, we believe this is the major, most effective way to bend the cost curve in healthcare. For CareCentrix, when we think about post-acute care, we see 25% of costs in Medicare are attributed to post-acute care. And by that, we define it as any post-acute facility, skilled nursing facility, institutional rehab, long-term acute care, as well as those services that take place at home, home health, DME, home infusion, and readmissions. And what we see is the spend in this area is continuing to increase significantly, and that the variability that exists in healthcare is focused primarily in post-acute care. You look at the regional variability, the plan variability, and where those costs look different from plan to plan, from city to city, from hospital to hospital. Almost a significant percentage, 73% of that variability is driven just from post-acute care costs. So what we find is a system that is siloed with each of these post-acute areas managing individually and managing profit centers individually. By managing the patient holistically, by managing their care holistically, we believe that 20 to 25% of that cost can be eliminated. When we think about post-acute care costs, and in Medicare specifically, more post-acute care patients is generally leading to higher costs. And when we look at Medicare across fee-for-service and Medicare Advantage populations, what we see is about 20%, 1/5 of Medicare Advantage patients are going to a hospital in a given year. And of those, around 42% are using post-acute care in one form or another. This is a median view. As we continue through the presentation, we'll demonstrate a number of different areas where we see the significant variability in how this changes across different markets and different clinical conditions. But what we find here is identifying the most appropriate setting for care and provider for each individual patient delivers significant value. One of the additional areas that we want to highlight is on the left-hand pie chart. You'll notice the purple sliver, which is almost 50%, is home alone. Traditionally, we don't think about patients who leave a hospital and go home without care as part of the post-acute care continuum, or patients who can be effectively managed through post-acute care. What we find is this is generally a large gap in the way management of post-acute care is done today and thought of. I think it's a huge opportunity for value, specifically with readmission. So today, post-acute care is viewed in many different ways and defined in many different ways. At CareCentrix, we take a very comprehensive end-to-end holistic view of this, and we think it's critical to take this approach in order to have an effective management approach. So if I orient you to this slide, this is what we generally see for typical Medicare Advantage health plans. If I start at the bottom, we see that about 30% of a health plan's medical expenditures for Medicare Advantage are going to come from skilled nursing facilities. This is a common area of focus today when we think about post-acute care, and a huge opportunity to limit length of stay and limit overall utilization. And at the top of this bar, we see home-based care, which we generally find to be about 1/5 of a plan's expenditures. Now, that's higher than many people generally associate with home-based care, but most of that is because home-based care can be broken down to many subgroups. But really effective home-based care is critical. And then the purple and light purple and light orange bar in the middle is an area that I mentioned before that we think is generally missed when thinking about post-acute care. It's a hidden cost that's not considered but really should be, and this is readmissions. Readmissions, the expenditures from patients who are readmitted to the hospital are generally 50% of the post-acute care costs for a health plan. And of those, 25% of all post-acute care costs are for patients who go home without any care. Traditionally, we don't think about them as post-acute care patients because they're not receiving post-acute care. But effective post-acute care, effective home health, effective care coordination can significantly limit those readmissions and lower costs significantly. With that, I'm going to hand it over to Karen, who's going to take a moment and walk us through identifying pathways for care and how to really do this effectively.
Thanks, Marcus. Good afternoon. In order to optimize post-acute care management, the key questions are, where should each patient go after an acute hospitalization? And how does one ensure that they get the best of whatever is right for them? We believe when patients are properly selected, that recovery at home provides clinical outcomes that are at least as good and many times better than with facility care. The costs are much lower, and patients, for the most part, prefer the comfort and convenience of being at home. When they cannot be appropriately managed at home, it's important to think through the type of setting, which of the facilities in that type are best for their particular condition, and to pay attention to the length of their stay in the facility as well as the level of care that they receive there. So, what levers can be pulled to effectively manage post-acute care to meet patient needs for healing and rehabilitation? This chart is an example of the variability in discharge patterns that we see in health plan data. After acute hospitalization for the same conditions, different hospitals discharge to different types of facilities. The patterns are remarkably inconsistent. So here, let's look at a typical DRG seen in PAC. Excuse me for the abbreviation, but it'll make it go faster. We're just going to look at major joint replacement, 470. And let's just, for simplicity, look at the second line, the skilled nursing or SNF line in this slide. Here we see the transfers to SNF after hip or knee replacement range anywhere from 22 to 40% among the 3 different hospitals that are in the same geographic area. Now, of course, it's possible that patients who are at Hospital B need SNF twice as often as Hospital A and C patients, but it's extremely unlikely. The variability is much more likely to be due to factors unrelated to patient needs, things like bed availability, discharge habits of discharge planners, and physicians, for example. Addressing this variability can reduce costs and, as we'll see, even reduce readmission. So what does that degree of variability in the type of PAC placement end up costing? We would assume that more intensive care costs more, but how much more? Here we see the results of a report that was published last year by the Medicare Payment Advisory Commission. They looked at stroke, hip fracture, and coronary bypass procedures, and they reported on the average cost for an episode of post-acute care in 4 different types of settings: home health, skilled nurse, inpatient rehab, and long-term acute care. And the differences are huge. We're seeing differences of $4,000 to $6,000 between home health and SNF, and $20,000 between home health and long-term acute care. But is the higher cost bringing about better outcomes? Well, in the next slide, you'll see Dobson and DeVanzo studied whether patients really needed the level of post-acute care intensity that they were discharged to. They reviewed CMS claims data to which they applied clinical guidelines to determine the appropriateness of the PAC placement. And what they found was that it was often inappropriate. You can see based on the kind of facility, the extent to which the placements were inappropriate. That is to say, patients could have been discharged to a less intensive setting and done just as well at a much lower cost. Of interest to us, their data shows much the same as what Marcus was referring to before, that the variability in appropriate placement is tremendous. This is true across markets and across diagnoses. Now, it's well known to this audience that small portions of the population are going to drive much of the PAC expense. So if we did a better job with PAC site of care, what would that mean in terms of savings? Let's again look at the same DRG 470 for major joint replacement. We find that an average of 40% of patients after joint replacement are transferred to a SNF. Again, the range is enormous. It's anywhere from 30 to 60%, depending on where we're looking. As we saw in the last slide, a number of these patients can be safely redirected home. So here's an example of a Medicare Advantage plan with 50,000 lives. On average, epidemiologically speaking, 300 members will end up with hip or knee replacement each year. So depending on this plan's baseline SNF utilization rate, the savings of redirecting to home with proper support can amount to $500,000. So, with cost savings of redirecting home being this attractive, let's look and see about the clinical quality of the redirection. Last year, JAMA published the results of a prospective randomized clinical trial that was done in Australia. The authors looked at recoveries for patients with uncomplicated hip replacements in two different settings, monitored home health versus inpatient rehab. The average age of the population was 67, and there were 165 patients in each arm. At 26 weeks, by objective measurements, there was no difference in the 6-minute walk test. And importantly, subjectively, patients reported no difference in pain or function at 26 weeks. There was a trend toward more complications in the inpatient group, which if you think about it isn't too surprising given the risk of being in an inpatient facility, but the trend didn't achieve statistical significance in this sample size. We've seen that in the US, if a patient goes home first, the average savings is at least $5,000. So, with comparable clinical results and patient experience for a condition commonly seen in the post-acute setting, when the savings are this large, why aren't they realized more often? Why are so many hip and knee patients sent to SNFs to recover? There are multiple reasons, of course. We think some of the biggest are there's a belief among families, physicians, discharge planners, that patients who live alone can't go straight home. For these patients, there can be an automatic referral without considering the option of adequate support with home health services. There's another factor. As a physician, I can say this. Doctors have habits. It's what we've always done. This is a big part of the remarkable variation we see even within the same market. A population health director at a major health plan recently told us that at one hospital, 15% of their patients are transferred to SNFs after joint replacement. And at another hospital just a few miles away, 40% of clinically comparable patients go to SNFs. Finally, patients' needs must be considered. Can they afford food? Do they have transportation, et cetera? Sometimes it can be easier to refer patients with socioeconomic needs to a SNF. but that doesn't resolve the issue, it just postpones it. If these problems aren't addressed, the patient is going to be at high risk of readmission whenever they get home, whether it's straight out of the hospital or after a SNF stay. So I talked about patients after joint replacements, but what about complicated medical patients? And what about the cost of adding home health services? Well, medical patients with multiple comorbidities may be overwhelmed by their recent hospitalization. They're weak, fatigued, they're often scared. They may be on meds that increase their confusion. Their diabetes meds may have been adjusted, leading to episodes of hypoglycemia. For these patients, adding home health services can decrease total costs by preventing the readmission that would otherwise occur. This is an analysis that was done by Avalier. They looked at 3 chronic conditions: COPD, diabetes, and congestive heart failure. The authors compared the cost for clinically similar patients who were discharged home with care versus those who were sent to a post-acute care facility. The range shown in this slide corresponds to the severity of their condition. And in this case, the savings came from both eliminating the facility fee and reducing readmission. In other words, the quality was better at home. Avalier estimated that CMS could have saved $1.7 billion if the appropriate path of care had been followed during the 2 years of their study for just these 3 conditions. So the Avalier study was reported in 2009. Well, what's happened since then? Lots has changed. Last year, in the American Journal of Medicine, the Cleveland Clinic reported on a retrospective analysis of their complicated medical patients who went home with care versus those who went to a facility to recover. And their results validated the Avalier report. The Cleveland Clinic patients who went home with care had fewer readmissions and fewer deaths than those who were discharged to a facility. And the cost differential was $6,500 less for those who went home with home health. So let's look at the potential savings for medical patients. In the same MA plan with 50,000 lives we looked at before for major joint replacement, we'll estimate the savings accrued from clinically appropriate discharge to home with support for COPD. These patients may be on home IV antibiotics. They may have been started on home oxygen. They often need substantial support with home health services. But adding home health and going home first yields a $5,500 savings. Using conservative estimates of prevalence and frequency of annual admissions for COPD patients, this plan could save over $1 million a year. And again, this savings comes solely from providing appropriate care for just one condition. So of course, some patients are still going to need transfer to a post-acute care facility. Our goal is that ultimately all patients will heal at home, but we're not there yet. In these cases, it's important to manage the SNF length of stay to meet the patient's clinical needs and not administrative schedules. We want patients to receive the care they need for exactly how long they need it, no longer and no shorter. When we look at health plan data, we'll often find this graph of length of stay versus total number. The spikes you see at days 7, 15, and 21 demonstrate the authorization period or the Medicare fee-for-service cost shift to the patient. They certainly don't represent the patient's physiological needs or clinical course. When you have RNs who go on site to work with patients and discharge teams at the SNF, some of these patients could go home sooner. On-site clinicians can ensure that patients get the appropriate level of care as well to meet medical necessities. So the keys for appropriate clinical path management for a health plan are: number one, know your basics. Understand your discharge patterns, find outliers for SNF admissions, identify opportunities. which patients get the most benefit from SNF support, and which facilities achieve the best clinical outcomes by condition. 2, have clinical protocols to optimize setting of care and length of stay. For scheduled procedures like joint replacement, begin the PAC process before admission with prehab and plans for home rehab. 3, use home first as the default discharge path. And then make sure the needs are met when they get there. In fact, many patients prefer to heal at home when they know the support will be there. 4, evaluate if an increase in home health services is needed. Are the home health costs low because there's too much SNF usage? These are some of the factors to consider in effective management. I'm going to transfer back to Marcus for further discussion.
Thanks, Karen. So we've spoken a lot about some of the challenges and the opportunities. Now we want to talk a little bit about what this means and how can we apply programs, solutions, approaches to improve the member experience and to improve outcomes and drive savings in the post-acute care arena. As we've mentioned before, post-acute care is a complex, often convoluted experience for patients as they're leaving the hospital and trying to navigate the many different settings of care and providers of care that they are working with in post-acute care. We see too often too high utilization of skilled nursing facilities and institutional rehab facilities. In many cases, we see too few or too little use of home health care, appropriate home health care, which can lead to an increase in readmission. Patients are not getting home health care when they need it. Patients are often getting higher levels of acuity care that they need. So what is the approach? What is the solution? How can we better address this? We take one specific example. It starts at discharge. Here we're showing 2 patients. We'll go back to the same example where these patients are both receiving a hip replacement in a hospital. We recognize today that the hospital experience is extremely intense and often overwhelming for patients and their families, and that discharge planners are extremely busy. What we find is that the decision in terms of what setting, what level of care, and even what provider, what facility is chosen is often driven by non-clinical, non-social factors and are driven more on items like referral, places they know, familiarity, and location. Recent studies have shown that 70 to 80% of the decision-making process for what skilled nursing facility a patient chooses or is directed to is driven by its location, not by its quality or its fit for that patient's individual needs. We think today these 2 patients, in many cases, as Karen mentioned, they may go home if that is the hospital's preference, or they may end up both at a skilled nursing facility, may be both directed to the same skilled nursing facility because it is a facility that the discharge planner knows they have had good experience with. It is a 5-star rated facility. However, if we dig a little deeper, we can look at the patient on the left. He's older. He's living alone without access to a car, which will make getting meals more challenging. He has a number of significant medical conditions and comorbidities that may make a higher acuity facility more appropriate. Conversely, the patient on the left is younger. She's got a support team of her husband and daughter at home with her and doesn't have nearly the level of medical history that the patient on the right has. As we put all of these factors into an intelligent analytic platform that uses as much data as possible to learn and make recommendations, what we find is we can develop an optimal path of care. And so leveraging these analytics, we identify the right settings of care, the right providers of care tailored to each patient's individual needs, using much more information than simply the condition or the treatment that they received in the inpatient setting. In this situation, the patient on the left, who had a number of other comorbid conditions and who, didn't have support at home, going to a skilled nursing facility, a high-quality skilled nursing facility, might be the right place, followed by supportive home health. While the patients on the right, who didn't have as many comorbid conditions and had a better support staff at home, going home might be the right approach for her. The difference between both the estimated costs for these and the downstream health lowered readmissions for this type of care is incredible. And these are the ways in which we can drive down the post-acute care costs. When we think back to the beginning, the 20 to 25% of post-acute care costs that we see, these are the initial steps that happen at the inpatient setting to drive that care, drive that high quality care, and drive down those costs. So as we think about doing this holistically, an integrated approach is critical. We need to follow these patients collectively through each of the points of failure, each of the synapses, each of the handoffs through the post-acute care continuum. That starts at the hospital that we just discussed, making sure the right setting of care, where that patient needs to go after discharge is chosen. And then it continues in a holistic manner, understanding what happens in the inpatient setting if they're going to a post-acute care facility, to understand how long is the appropriate amount of time, as Karen alluded to, not necessarily how long does the facility have an authorization for, or how long the facility thinks the patient should go there for. And then how can you ensure that when that patient is in the post-acute care facility, they are receiving the care they need to not be readmitted. We find many times that readmissions occur in the first few days, the first 3 days of a patient's admission to a skilled nursing facility. Many of those readmissions are due to a failure in the handoff between the inpatient setting and the skilled nursing facility. So it's not simply effective enough management to get that patient identified and get them passed to a high quality skilled nursing facility. That transition of information is critical. And that same approach needs to be taken when that patient is ready to go home. What do they need at home? How do we ensure that all of the medical supplies, providers, and care is aligned so that that patient does not go home ready to go home and not have the right support and supplies that they need? Once that patient is home, how do we ensure that we prevent hospital readmissions, prevent this cycle from occurring again and unfortunately again? When we think about readmissions, again, come back to the term comprehensive. We use comprehensive, integrated, end-to-end. We use a lot of these terms. We find we use them a lot, but we use them because they are critical and because they really do work. So it starts at discharge and making sure that the member understands that. And that can often be as simple as reciting that back when that member is out of the inpatient setting and in a place that they are not as overwhelmed, to medication reconciliation, which is a blocking and tackling approach, but is fundamentally critical for non-clinicians who may end up with 2 brands with different names on them. It's just the same medication, all the way down through getting social barriers and identifying the non-clinical needs that patient doesn't have access to transportation that's needed for food, making sure that gets set up, making sure that patient understands all of the care they need and getting them scheduled for those appointments that are going to be needed for them to be successful in managing their own care. As we step back and say, how do we do this? What are the key action steps? Again, making sure that we understand how to remove the silos from post-acute care, how to connect these disparate players in this system and ensure that they are all aligned, talking to one another, which requires clinical coordination, alignment of network, and throughout this process, ensuring that we're preventing readmissions, as well as engaging patients and caregivers to ensure that all of this care is continuing and the patients can ultimately meet their care goals, successfully not be readmitted, successfully exit this post-acute care, acute care, healthcare experience. And so for CareCentrix, we firmly believe that the home is the center of care. And our approach takes this into account, of managing post-acute care all the way through all of the services that a patient may need at home, whether that be home health through the right amount of sleep services and home infusion. We leverage a purpose-built care coordination platform to ensure that those handoffs and transitions are monitored and maintained throughout that post-acute care time, to ensure that no gaps in care exist and to ensure that every caregiver and every person involved in that patient's care is aligned and is sharing information. Leveraging logistics to identify right support for the patient, using machine learning to match patients to their optimal providers, and engaging members throughout that care continuum to have them be active participants in their care. And with that, I will hand it back and ask if there are any questions of the group.
Thank you, Marcus, and thank you, Karen, for your insights and the information and experience that you presented in a clear and concise way. And as you were going through the examples, and I've been monitoring the questions here, this parallels as well sort of topic number 2 on the HCG top list, which includes those social determinants of health and how all of that gets incorporated into the considerations that you've been discussing. I want to thank all of you on the call for your interest and your participation, and for all the questions. We're trying to sort those out right now. There's some of the questions that are more clarifying questions on the data and the statistics, and there's been several of those. We will respond, CareCentrix will respond to you specifically clarifying different locations or what percentages were being referenced and the sources of that. But there's also a number of very substantive questions that we want to address. There's one here that came in just recently on the cost data, and we get caught up in this in healthcare all the time, Karen and Marcus, looking more short term. And sometimes the question is that the costs sometimes are much more initially, but you avoid longer term costs, even out to the 3 to 5 year period of time. Any comments on and any experience on how organizations can balance that short term versus the long term, and whether your data has looked out long term yet at this point?
Yeah, I mean, I think that's absolutely true. I'll give an example of one that I think is near to a different program that we see specifically in sleep, where we find that getting patients, 80% of patients today are unfortunately undiagnosed who have sleep apnea, and that upfront cost will increase, but getting them healthy is critical to long-term success. As it relates to post-acute care, we think about it probably even more broadly, and we think about it in terms of really aligning care coordination. As we align appropriate care coordination, we will drive better outcomes, which will ultimately have lower costs, both in the short term and in the long term. And so some of our actions, we think about something like skilled nursing facility average length of stay, which is a hot topic today. And a lot of vendors, a lot of health plans will talk about what's the reduction in average length of stay, and how does that correlate with cost savings. The converse of that is, if we remove patients who don't need to go to a skilled nursing facility and send them home, we have a potentially more acute population in the skilled nursing facility, and the average length of stay will actually go up. And so the cost there on a per patient basis may actually be higher, which for us is exactly what we want to do. So it's aligning the care and the appropriate level of care to each patient. And holistically, that will drive down costs and really kind of improve outcomes. It's a harder thing, we'll be honest, a harder thing to do in the short term, as given the nature of the healthcare market today, health plans, health systems are looking for immediate savings. And so we love partners who will look to us and look for, 4, 5, 6, 7, 8 year value as well. But we also recognize that driving immediate savings is one of the linchpins to what is really a need and a desire in the market today. I don't know, Karen, if there's anything you want to add.
I referred before to habits, as patients have friends who go straight home after a joint replacement. It's not going to seem as strange to them to be offered that. And as physicians and discharge planners become accustomed to transferring patients home with care, that's going to help fix the problem. And that will take time and will require incentivizing or prodding at this point, but eventually that's going to become more than normal.
Great. There's a broad question here where this focus is primarily on Medicare Advantage. Is it different? Does it work for the commercial populations? What's your experience there?
Sure, I'll take this question. It works perfectly. The readmission reduction model is just the same for commercial or for Medicare Advantage. The big difference, obviously, is that with a commercial population being younger, you typically see fewer facility admissions. And so you're not always going to see as much savings per member, but there are far more commercial members typically. So you can use a readmission reduction model just like ours and achieve significant savings.
Yeah, I think if you, in an early slide, we mentioned that for a typical Medicare Advantage plan, half of the expense is for readmissions, and of that, half of that expense is for patients who go home without care. Both of those numbers for a commercial population are increased to more like 60, 70, 80%. So readmissions becomes an even more critical driver of care and savings in a commercial population. And then we think about technology and engagement for those patients is even more critical, as commercial patients can be more challenging to get a hold of. So leveraging that technology to get a hold of them and to get them engaged in their care is extremely important. But overall, the tenets of it are very similar. It's just a focus more on patients' care at home with or without care, and less on a skilled nursing or other post-acute care facility.
Excellent, thank you. There's a number of questions relating to the AI machine learning. I guess I'll kind of combine them, but you had mentioned that the post-hospital care coordinators are overworked, overtaxed, and there's agreement from the questions that are following. The question is there data or insight that you have on the improved efficiency for that group using the AI tool?
Yeah, that's a challenging question. And what we have found is the only way to be successful is to be helpful, to be a partner, and to lower the amount of work that a discharge planner today has. And so what we found is it's not simply giving another technology or a piece of information or tool. It's really figuring out a way to work collaboratively with them. And I think today in our society, where we've become so accustomed to the TripAdvisor, Yelp recommendations, to be able to aggregate that information and take a disparate set of 50 or 100 post-acute facilities and drilling down and saying these are the top ones because of these reasons, to provide that information to the discharge planner and be extremely helpful. Now, we don't unfortunately have a way to quantify that. And what we found is certain hospitals will open up their EMR systems to some levels, certain ones won't, and it's a much more manual process. But I think across the board, the only way that we've found ourselves to be able to be successful is to provide a service that is valuable and improves the efficiency of the discharge planner's day-to-day experience. And it can be as simple as, we think about the importance of machine learning and the importance of taking that data to say, based on this patient's clinical conditions, social determinants of health, all these other factors, that this provider is going to be the right one. Equally important to that is just knowing whether or not that provider has an open bed, for example. And so some of it is really also logistic support and making sure that the recommendations are for providers who have capacity. So,
and I would say, along with that logistic support, as important as the machine learning is, having an individual on site who can work through a complicated transfer, either home or a facility on a Friday afternoon, and get the approved in a timely fashion at 4:30 on a Friday, can be a game changer for efficiency.
And sort of building on that, Karen, and thank you both Marcus and Karen for the response there. In the presentation, of course, it's sort of oriented towards market-driven focus, but as we see from our HCG membership with the total consumerism and the digital and mobile technologies and like that, the question really is, how do we bring in the patient-centric focus that's needed in the decision-making that's being made as to whether you go to home care or not? Is the patient and the family still offered choice and some involvement in the decision-making, the quality of care like that? Any comments on that broad question?
Yeah, absolutely. So I can tell you personally, I had a colleague at CareCentrix who had a family member who needed a skilled nursing facility, and they went on CMS Compare. And there was a professional working in the post-acute care industry who was overwhelmed. And so I think patient choice is ultimately critical, and it will override many other factors. But unfortunately today, patient choice doesn't necessarily mean it isn't provided in a way that can be necessarily helpful. If I'm a overwhelmed patient with a family, I'm provided a sheet of 50 skilled nursing facilities with very little information except their address. I have lots of choices, but it's not really informed choice, it's not help. So CareCentrix will never offer one single path of care. We'll offer a number of paths of care, which we think are the best path of care based on these algorithm machine learning and matching patients to their needs and providing information about them as to why they're chosen. If this skilled nursing facility has expertise in patients with sepsis, and this patient has sepsis, right? Why why they are the right places with a number of different options to let the patients really understand, call, reach out, get that information earlier so they can make that informed decision. But what we're really trying to do is increase transparency and provide critical information to facilitate that decision-making process. But ultimately, having an engaged patient and caregiver team and family is critical to having a patient successfully heal. So we think that's fundamental to everything that we do.
You know, Marcus says it very well. We absolutely believe in patient choice, and in fact, Medicare requires it. We work very hard on developing what is a very important part of our program, which is the bond between us and the patient and their families. Our liaisons in the hospitals are getting to know the patients and working hard to figure out what it is that will best allow the patient to heal as well as possible. Wants them to be comfortable and particularly wants them to be informed. Sometimes it's the patient, sometimes it's the patient and their family, sometimes it's just the family. That bond then allows the transition of care to go smoothly so that once the patient is home, they already have a relationship of trust, and that smooth transfer can be supported for the duration of the program, typically 90 days. It allows us to catch things that would have otherwise fallen through the cracks.
I'm trying to prioritize questions. Thank you, Karen and Marcus. There's a wide number. There's a question from a plan-oriented responder that if you have a narrow network, how do you avoid provider abrasion with a strategy like this? There's another question saying, you know, what if a clinician says, I don't need more algorithms? They want to go in a different direction. How do you deal with the provider network in these kinds of decisions?
Yeah, so, you know, taking some of the fundamental approaches that Karen mentioned of you know, being on site and collaborating, some of those same fundamentals apply to the provider network as well. And so one of the truths of the matter is that if there's an underperforming provider and that data is shared more broadly, they may be unhappy that they're getting less cases. But we work very hard with, whether it be a broad network or a narrow network, to share the same level of information, both with the hospital discharge plan with patients and plans, and back with the provider networks to identify, you know, where there may be areas where a provider is performing well, or where there are areas where they may not be performing well. And what we would, our goal is to work collaboratively with every provider to ensure that they're getting cases that they can effectively manage and they can take care of patients the best that they can. So, you know, we think that transparency goes both ways. It doesn't just go to people making the decisions on where they will go for post-acute care. It also goes to those post-acute care providers. And I mean, I wouldn't sugarcoat it and say that providers will love this approach. I mean, but I will say that in the market today, there are programs that exist that are just very, very strict UM. You know, we don't think of ourselves as a UM program. We really think of ourselves as a clinical management, a clinical coordination approach first, because we're not necessarily trying to lower utilization. We're trying to get appropriate utilization, and to do that, we have to partner with providers. But if it is a provider that is in the market that is not performing as well, you know, we will work with them and try to figure out how to do that the best that we can to improve it. Now, every market has local nuances, and every health system has local nuances and ownership structures, and so I won't sugarcoat the challenges that exist there. But those are challenges that we deal with every day, and ultimately sharing outcome information is very effective. We think that almost everyone who works in healthcare ultimately is trying to do best for the patient. So by sharing that information with as many people, we think we ultimately can drive care to the areas and settings and providers who are most suited to deliver the best outcomes, which drives lower costs.
This has been terrific. I want to thank especially you, Karen and Marcus, for your contributions. I'll close with an HCG slide, which is that we're currently gearing up for our 30th anniversary annual forum, September 12th through 14th at the Hewing Hotel in Minneapolis. Our theme is guiding healthcare executives through innovation, change, and growth. And we'll be discussing, these topics and others as to how technology and innovation and the market dynamics are affecting the changes in healthcare and what the best and the brightest in healthcare are actually doing. If you want to join us, on the final slide is Juliana's email address, jr@hceg.org, or you can go to hceg.org, our website. We encourage you to plan on continuing this discussion and all the questions that have come in during this webinar with CareCentrix and our other sponsor organizations and the 120 to 150 healthcare executives that will be there. And between now and then, we wish you the very best, and please watch for the announcements on upcoming events like this. Thank you and have a great day.